Rotation, lateral bending of the thoracic spine.
Okay. Once again, for rotation and lateral bending of the thoracic spine in a seated position, very similar to the lumbar spine we covered before. The only difference is your segmental contact points, for the most part, instead of being the spinuses and the mammillary processes, are going to be the spinuses or the TVPs. Once again, for this test, the choice is yours. Anatomically locating it, the nearest landmark or shortcut is going to be the inferior border of the scapula. If we bisect this, it usually gives us to the spinous process of T7. For this examination, it'll either be T7 or T8. Either which way, that's probably the shortest landmark for finding this. In rotation, for the most part, we're going to be using either a spinous process or TVP contact. For the spinous process contact, in this case, I'm going to assess is left rotation of T7. My segmental contact point is going to be the lateral aspect of the spinous process of T7 on the left-hand side. My line of drive relative to the spinous process is going to be from lateral to medial, from left to right. If you choose to use a mammillary process as your segmental contact point, realize that in order to induce left rotation, you're going to be pushing on the right mammillary process. A la Dr. Browning's class, to locate the TVP, if this is your choice, I first find the spinous process of T7. I palpate two inner spinous spaces up from that point, and then out laterally to the right about an inch. And your line of drive relative to your segmental contact point being the TVP, in this case, is going to be P to A. For either maneuver, your doctor's position is relative to your segmental contact point. And if you choose a spinous process, as a doctor, I want to bring my side laterally to the patient such that my body weight can fall into the line of drive from lateral to medial. If you choose a TVP as your contact, your doctor's position, you want to be a little bit more posterior so that your body weight is in line and can fall basically into that same vector of P to A. We're going to look at two things when assessing lateral bending and also rotation. One is going to be joint play, and one is going to be end play or end feel. Joint play rests between neutral and the end of pre-adjustive tension. So to do this, what I'd like to do is first, I'm going to use the spinous process as contact for left rotation. I'm going to bisect the inferior angles. I'm going to find the spinous process. I'm going to use a thumb on the lateral aspect of the left side of the spinous process. And just like we had beforehand, I'm going to let my base of my thumb spy on the inner space, across the inner space to the T8 spinous below. And this way I can feel the relative movement between the two segments. My indifferent hand, two ways of capturing, is one, I can drop it over the front side of the shoulder and then grasp the nape of the neck to cause rotation of basically the thorax. Or if you like, have the patients fold their arms in front of them, and I can reach across and either grab the shoulder or the contralateral arm. From here, what I'm going to do is I'm going to rotate the patient to the left, and what you should feel if there's normal play or joint play is a spinous process should separate. In this case, the superior one will begin to separate from the inferior one. And that usually indicates that chances are you're going to have a normal end feel as well. It's not always the case, but it's something. We're going to bring that joint to pretension. How do we know it's at pretension? Because you soon feel the superior one begins to move. Well, as soon as the bottom one begins to move, you've brought this joint to pretension. Once I feel that joint's at pretension, my indifferent hand does nothing more than stabilize the patient at that position. From here, I'm just going to let my body weight fall from lateral to medial into that spinous process about 1/8 of an inch, feeling that give as the tissue stretches and the recoil as it returns. In a normal joint, it should be giving, it should be springing. It should give as you push into it and should recoil or spring back as you let go. In a restricted joint, you'll often not feel that movement, and the springy quality may be very reduced or at least absent. In this case, this would be left rotation. If you choose the mammillary process as a contact, I'm going to palpate two inner spinous spaces up and over to the right side about 1 inch. My doctor's position comes a little bit more posterior. As you begin to, I'm going to compress the overlying musculature so I feel firmly against the bone. As I rotate them to the left, which you should feel for normal joint play, you may get the impression of the TVP above from the TVP below. The TVP that you're on is going to feel as if it moves forward or steps forward the other one. That usually implies there's good joint play. If you feel the two TVPs move together as a team, you usually say that your joint play is reduced or absent. As to bring this joint to pretension, as you rotate the body, you're going to stay with that TVP, and it's going to feel like it moves effortlessly forward, and then you'll feel a back pressure or resistance come in. That means you've brought that joint to pretension. Once you feel that back pressure, the indifferent hand stabilizes the torso at that point. It's done its job. From here, I'm just going to lightly spring 1/8 of an inch, feeling both the give and the recoil of the tissue as I let go. And this is going to be left rotation using a transverse process as a segmental contact point. For lateral bending, just as in the lumbar spine, your segmental contact point is the same. It's the lateral aspect of the side of the spinous process to the side of motion you're assessing. I'm going to assess left lateral bending, so I'm going to be on the left side of the spinous process. Just as we did in the lumbar spine, I'm going to use my thumbs, going to be on the tip, basically on the lateral aspect of the spinous process, with the base of my thumb spying on the inner space below. So this way I can feel the movement occurring between the two segments. To create lateral bending in the thoracic spine, in review, for the lumbar spine, there's two ways to create lateral bending. We can basically pull the torso over, or we can compress down on the ipsilateral shoulder. As a general rule, as you pull the torso over, it'll cause a curvature to come more down more inferiorly in the lumbar spine. As you compress on the shoulder here, it tends to cause the curvature in the spine to move a little bit superiorly into the thoracics. So generally for T7, T8, you're going to have to compress down on the ipsilateral shoulder to do this. Well, how do I do that? Well, one, if you like to capture that same capturing from here, I just begin to lean down onto this arm to begin to laterally bend the torso. If you're one who likes to grab across the front side of the body, what I would suggest is basically take your armpit and drape it over basically the AC joint, or the lateral aspect of the shoulder. Because in this way I can just take my body and sink down, and it causes the spine to laterally bend. We're going to look at the same two things, joint play and end play. So with my fingertip on the side of the spinous process and spying on the segment below, I'm going to cause laterally bending of the torso, and I'm just basically going to feel the movement. What will you feel? The spine, whether it's restricted or not, will always feel as it translates away from you as it begins to bow. What you want to pay attention to or look for is, do the two segments that you're palpating, as you laterally bend, do they move away as a solid team, which would imply there is no joint play? Or do you feel movement between the two, which sometimes we refer to as buckling happening between the two? That would imply a healthy joint play. Either which, by the time that you feel the spine translate away or you begin to feel the buckling, there's so little lateral bending in the thoracic spine, you've already brought that joint to pretension. So once you get to that point of pretension, now the question is, the indifferent hand stabilizes in that position, and once again our body's positioned so we can just lean our body weight that 1/8 of an inch to spring through the joint, to feel the resiliency. In a healthy joint, you should feel continued movement and continued buckling. In an unhealthy joint or restricted joint, it'll be minimal to absent at best. In this case, your line of drive relative to your spinous process is going to be lateral to medial. Your segmental contact point, once again, is the lateral aspect of the spinous process. And that would basically conclude lateral bending of the thoracic, the middle, and the lower thoracic spine in a seated position. And we got a body over here. As a matter of fact, can I borrow you, sir?
Yes, sir. Do I need to have my shirt on or off?
Off would actually probably be better.
Okay.
Seat over here facing around. I'm just going to move you a little bit over there. In front of you there. I'm just going to do me a favor, can I have you fold your arms in front of you? And I'll tell you what, stand up for a second. I'm just going to turn it so we can get a little bit better light. Okay. Go ahead and sit this way. Over there.